Okay, guys. So today we'll be talking about two chapters, which are the excuse me, the effects of radiation exposure. So, what are the things that we can get from the radiation? And then we'll talk about radiation safety, if I'm not wrong. No, I forgot. Chapter 6, protection. Yeah. How can we protect ourselves from these problems or effects of radiation? Generally, generally, dental X-ray is safe, as we've talked about before. And again, with the development of the digital films and the uh, digital, X-ray, it just became less and less harmful because the dose that we are giving the patient or we're administrating is much smaller. So generally, it's just becoming much more uh, safer. But technically, we still need to follow ALARA, right? And in any way, we would have to consider any uh, amount, even if it's really small, to be harmful. They cannot really measure, that if they try to measure the actual problems that can happen because of an X-ray radiation, you cannot really measure it on a cellular level, especially when the dose is really small and there's no really noticeable or detectable damage to the cell. So we cannot really know if a small amount of X-ray can harm really or not. But again, because on the long run, yes, it will. And because it is an ionizing radiation, so we want to make sure to protect ourselves and consider it as always as a health risk. So we know that the ionization can damage or destroy cells. The good thing is, I mean, again, this is just a general thing about what we're talking about. This kind of sums it up. Our healthy cells usually can prepare any damage that can happen to them. A lot of times, there's no damage in the first place that will happen, when we expose X-ray. And definitely the benefits of radiographs would outweigh the minor risks that we can have of exposing the patients. So, the first skin-induced cancer because of the dental X-ray was reported around that time. And then nowadays, we don't have a lot of or any reports of injuries since we have the safety rules. Now, we know the problems, we know the issues, and we started to take safety measures like wearing the lead apron, having the 6 foot distance, lowering the radiation and all of that, not holding the film inside patient mouth, and so on. So this is an early picture, an old picture, seen many years ago, where a dentist had an early carcinoma, which is technically a cancer in their skin. This is their finger. And the dentist actually admitted that he was holding the film inside a patient mouth while exposing the X-ray. And he'd done it too many times. Again, they didn't know at that time. You see, the picture is in black and white. I think, that's how old it is. But anyway, they didn't know at the time that it was really making an issue or a problem. And that's why, again, they had that carcinoma. But nowadays, we don't really have that. It's really rare to see anyone that is affected by, again, but not to think that we should not take any safety measures. Looking at the finger picture, there are also some, what do they call that? Risks. I think I did say that, but when you do the light curing, if your fingers are close to the light and you do it multiple times, if you're holding it and the light comes to your fingers, it can actually cause some diseases. The curing light that we have, so keep that in your mind. Okay, and that's why we try not to really have our fingers next to the light. We're just holding it, stabilizing it when we cure. Anyway, so let's take a look at what happened when we have an actual damage that can happen to our cells. So there are generally two theories that can, of what can happen when we expose X-ray. There is a direct theory, which is technically a direct effect, and then there is an indirect theory, which is an indirect effect. So the direct theory says that ionizing radiation would change the chemicals in the cell, and that will cause the damage, and the amount to 1/3 of the biological alteration. So the direct damage that can happen because of the radiation can amount to 1/3 of any alteration that happened in the body. The good thing is, again, although this can happen, but still our cells usually repair themselves fastly, and then most of the photons would pass without any damage. The other theory is the indirect, again, how the X-ray would affect the cell. It will affect them indirectly by hitting the water, by ionizing the water that is inside of the cells. You know, our body is about 80% or 75% water, right? So all of our cells in our bodies would have water. So some of that ionizing radiation would actually hit the water in the cells, and this amount to, yeah, you guessed it, of any biological alteration that can happen. But again, fortunately, most of what happened would right away recombine. So technically, when the ionizing radiation hit the water, it will split it into ion, right? And then this can have, since it's an ion, it's a missing an electron, and then it can have uh, to form to or absorb a different ion, and then would form toxic chemicals. But again, fortunately, most of the time when that happened, they just recombine and they will form water again. So again, that just tells you that the effects, even that there are there, but a lot of times they don't really cause any damage because, again, it's not of a great extent. That indirect theory is also called radiolysis of water, or radiolysis of water. Anyway, so these are the effects that, or these are the theories behind the effects that can happen biologically on a cell level or cellular level of the radiation. So now we got that effect, right? We have the issue. And how would that be? How would the response be? So we have two type of effects that can happen, or two types technically of responses that can happen. We have detrimentistic effect and stochastic effect. You try to spell these, right? So the main difference between these is that the change that can happen, or the damage that can happen, does it depend on the dose or not? Yeah, that's what I'm saying. Yeah, I'm saying the main difference between the two effects that can happen is that, does it depend on the dose? The severity of the damage, well, that depends on the dose of the X-ray or not. So for example, the first effect, the severity, yes, it will depend on the dose, right? So the more the dose, the more severe the damage, right? So again, the severity of the damage relate directly to how much dose. For example, the damages that are detrimentistic um, is erythema, which is redness, hair loss, cataract, and infertility. So for example, if you give more dose, the redness will be more. For example, more dose, you'll be having more or severer hair loss, right? That's for this effect. The stochastic effect, on the other hand, does it occur or not? If it occurs, then it happens. It doesn't matter how severe the dose is or how much the dose is with the severity of the disease. For example, here, so more dose, more risk of the damage. It's not the severity of the damage. So, for example, the cancer, this is one example of that effect, cancer. So again, these are examples for the previous effect, and this is for this effect. Cancer is an example of the stochastic effect. So the more that you give the dose, the more the risk you get cancer, but not how severe the cancer would be. Okay? So it does not, the severity does not relate to the amount of the dose. And that effect is the primary risk of the dental radiography. So that's the main effect. So if you compare the two effects, the stochastic effect is the main risk for X-ray. Anyway, again, the simple way to look at it, does it relate to the severity of the dose or not? Does the severity of the damage relate to the dose? For this one, yes, the more severe, and for that one is not. And we know examples of each of the effects or the responses. Okay? I put examples for you guys. So after we do the exposure, after we get the exposure, there are technically some periods where, or when we see or not see the effects. So the first period where there is no detectable effect would be latent period, right? And then when you actually have the damage and you can detect it, that will be injury period. It can be permanent, that lasts for a few months, days, or weeks, or permanent, temporary or permanent. And then you have the recovery period afterwards where the body would recover. This can happen really quick without even noticing it, or it can happen where, again, we have like a cancer or something like that. So this is just what happened within the body after we get exposed. These are the different periods where the effects will take place and then recover. So will all X-ray produce effects? No, right? So let's see what happens, the 5 outcomes of the exposure that can happen when we do an exposure. Boom. So you can get exposed and you have nothing, no problems, right? You do not affect anything. Nothing is affected, no cell damage, nothing, which is most of the time. Sometimes we would have, we would have a cell damage, or I'm sorry, death. Actually, the cell would die, but then would be replaced normally. So again, we don't see any problems or issues, right? The body will just reheal itself. Sometimes the cell will be damaged and then would be replaced and then would work exactly like it was, right? It will function exactly like it was. The fourth outcome that can happen, we have a cell injury and it will repair, but it will work at reduced level. So it would not work as regular. And then the last one, it will repair itself incorrectly or abnormally. And in this issue here, in that fifth outcome, that's when we will have cancer, right? Or malignancy, tumor or malignancy. So these are the 5 outcomes of when we get exposed to radiation, what can happen within our cells. Again, most of the time you can see like 4 of the outcomes. Technically, you don't have really an issue. You might have a little bit of reduced level of production or function of the cell. Again, a lot of times it's not noticeable, but in that one time where you have it damaged and then incorrectly treated itself, that's when we have the tumor, and then the cell will start replicating at an abnormal level. And that's technically what cancer is. Okay. So what can actually affect the radiation injury? What can cause, or what are the factors that would make the injury from radiation more or less? So we have a lot, but the 2 main ones that we're talking about will be the cell age and the cell sensitivity. So let's take a look. The immature cells are more or less more sensitive than mature cells. So the cells that are still growing up, they're still dividing, they're still forming, would be more sensitive than mature. Then children, that means, will be more susceptible because, again, their cells are still growing up. There's a lot of division within their cells. Technically, a general rule, any tissue that is a reproductive tissue that causes uh, that is always growing, for example, is usually affected by radiation. And that's why people sometimes that go through chemo slash radiation therapy would lose some of their hair, because again, these will get affected in the way by, for treating the tumors. Anyway, the thing that happened also after the cell will really get older, within our cells, right? Our cells will get older as we go older. We actually have also going back to more sensitivity from X-ray, right? We said mature cells first are less sensitive at the beginning, but then as they go older, they get again back more sensitive because the reduced ability to repair themselves, right? We know that the cells would repair themselves usually if they get exposed to X-ray, but as they get older and older, um, that will reduce their ability to repair themselves. So that would happen. Okay. Tissue and cell sensitivity to radiation. So we have radio, and that is the degree of the susceptibility of the tissue to radiation. Sensitive and resistance. So tissues can be either radiosensitive or radio resistant. So the more mitotic or metabolic activity of the cell, the more sensitive it is, right? Where? Because yeah, again, mitotic means division, right? So the cells that get to divide more and more, and that's the reproductive organs, right? So the more, again, the more active the cell is, the more it will get affected by radiation. That's why immature cells, because they're still growing up, they get more affected, and so on and so forth. So other things that will affect the injury or the rate or the risk of the injury, variation in species, it depends on the species, individual sensitivity. Some people um are more sensitive maybe to radiation than others. The dose amount, definitely, the rate, and the area exposed. So the more and the more and the more, definitely will get more injury. The more amount, the more the rate, and the more the area, or the bigger the area that exposed, we can have more effects of the injury. So now, if we look at the cell sensitivity, if we want to see which cells are more sensitive than others, try to figure out, just put things in here, or, within your mind or in a paper, try to see and think which ones are more sensitive, which one is moderately sensitive, and which ones are least sensitive. Okay, so let's see. Mature bone and cartridge. Least, right? I think I made it too big. Let's make this a little bit smaller. Okay, so that is one. Mature bone and cartridge is one of the least sensitive. How about lymphocytes? Most, most sensitive. How about gastrointestinal cells? Moderate. Nerves and brain, least. About blood forming cells, they're forming, they're, doing a lot of work. So that means they're sensitive, right? Skin cells, moderate. How about reproductive ones? Most, right? And then lens of the eye, moderate. And then muscle cells, boom. So these are the sensitivity of the cells. Which ones are the most? And again, it's the ones that are most sensitive usually are the ones that are working, that are doing something, uh, reproducing, and so on. Okay. Huh? Oh, yeah, yeah. Take your time. Do, 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 do. We're good. So we get that. Yes. Moving on. Okay. So there are two effects that can happen within the cells. It can be a genetic effect. I know, I mean, there's a lot of kind of categories that we're talking about here. So just make sure you are differentiating between the titles that we're talking about. You know, here we have an effect, the biological, technically the response more than anything else, how the response of the X-ray would be with it, based on severity or not. This is how actually how the effect will carry on within our body. So it can be a genetic effect or a somatic effect. And you can see kind of white in here. So the genetic effect will happen in the hereditary cells, right? So these are the cells that have the genes. And does it happen in the person that gets radiation? No, it does not happen in the person that. So if, for example, God forbid, some of you or one of you or not of you, whoever is, a dental radiographer, they get, they expose X-ray a lot, and then they get that effect. It will not show up on them. They will not get the effect or the problems in their life, but their offspring, their sons, daughters, and so on, will be passed along. The problem will be passed along because now it's in the genes. So that's this effect. Yes, exactly. Like a genetic mutation that can kind of move on to the offspring. So the reproductive cells in our body, technically eggs and sperms. And the problem with genetic cells is that they cannot repair themselves. Again, as we're saying, these effects are not that common nowadays because we're taking all the safety procedures, our radiation is much less, and so on and so forth. But again, just to know the effects of the radiation, what can happen. So that is one side or one type of effect. We're good here? Yes? Moving on? Huh? Just move the thing bigger. Maybe the box, most probably. No? This should be the same document. They cannot repair themselves. Okay? These are the genetic cells. Okay, we're good. Moving on. Again, huh? Yes? No? Maybe? It comes up? Yeah, that's okay. And then we have a somatic effect. And technically, somatic cells are all the cells except the huh? Except the reproductive, right? Or technically the gene cells, right? So all cells are somatic, and then the other cells are the genetic. So again, because we're comparing the effects of the cells that happen in our body. So comparing to the genetic cells, these can kind of recover themselves about 75% within the first 24 hours when they get hit, compared to the genetic one, right, which are the reproductive cells. They cannot repair themselves. So the somatic have somatic cells, right? While the other one, the genetic one, happens in the genetic or hereditary cells. This one would actually be manifest in the irradiated individual. So the person that will get the radiation would get the issue or the damage or the disease, right? And this one, not pass along the offspring. So again, this is a comparison. You can see we have a genetic effect and somatic effect. The genetic one is in the genetic cells, the somatic in the somatic cells. This one does not pass. I mean, this one does not appear in the person. This one actually appears or shows in the actual irradiated, the person that get the radiation. This one will be passed along. This one will not be passed along. And these are the somatic cells, and these are the genetic cells and the differences between them. And then they call that effect is a cumulative effect. So as you add more and more, it will cumulatively, have more damage into it, technically. Okay, we're good. Got all of that information? Check, check, check. Okay. When we see, or when we try to see these damages, can kind of differentiate them into a short-term effect or damage and a long-term damage or effect. So from the name, definitely, within minutes, days, or after exposure, that's the short. So an example of a short-term effect is the acute radiation syndrome, which we'll talk about here technically. And then the long-term, you will not see it. So you work in the field for longer years, and then at the end of your career, you get a cancer. Sorry. Hopefully not. But anyway, that's an example. An example is cancer, embryonic defects, genetic mutations. That's the long-term effect of radiation. Okay. So the acute radiation syndrome, which is an example of the short term, is not a concern in dentistry, but these are the issues or the symptoms that it can happen. And again, we kind of talked about these. These are the main effects that can happen. So like erythema, which is redness, hair loss, diarrhea, and so on and so forth. So usually this is if you get a lot of radiation, very much radiation within a very short time. You get a lot of radiation within a short time. And again, because in dentistry we don't get that, so most of the time this is not an issue for us. Okay, so the main tissues that can expose or that are critical for our work are the thyroid gland, the bone marrow in the mandible, and the skin of the head and neck region, right? Because these are the areas that we actually, work with. But again, if you look at the risk of the cancer because of FMS, because of full mouth uh, X-rays, when they did the research, it's about 3 people in 1 million examinations. So out of a million examination, 3 people might have the risk of developing cancer because of the radiation that we do in the dental office. So there is a risk, but it's really, really narrow. And then when you compare the radiation that we give, the FMS radiation, to the naturally occurring background radiation, because we did talk about that before. There is a background radiation that comes from all kind of different sources, right? So it is about like 2.5, almost 3 days, you know, in the regular, in your life when you go out in your life, 3 days of the regular radiation is similar to our FMS. So again, this just shows that these are not as dangerous as we can see. And this is like the background radiation. You can see how much radiation we're getting from each type of uh, radiation source, right? Even foods and drinks have 10%, and so on and so forth. So there's a lot of radiation that we actually have already around us. And again, when we compare, it just gives you a picture of how bad or how safe actually is the radiation that we're giving our patients. Anyway, this is for reference only, so you can see how many days with a natural exposure for our exposure. So like when you expose a single radiograph, it's about what, zero point 0.2 day, and so on and so forth. Bite wing is about almost a day. Foreign films is about a day, and so on. You can see the CT scan, where the panoramic is more, the CT scan is a lot of the mandible, and so on. Again, this is just for reference, just to see how much the radiation compared to the natural occurring radiation. Okay, well, we're done with chapter 5. Moving on to chapter 6. So, chapter 6 is about radiation protection. And again, a lot of this information I think you guys kind of already know, but how do we protect our patients? What are the factors? And then how do we protect ourselves? And different information that is related to that. So again, we know that radiation can be harmful a little bit, but patients do agree on that exposure because we have a lot of benefits to that. They do sign a consent form for radiation when we take x-rays to say that they know that there are some risks. But anyway, that's again because they're really little. Most of that is not harmful, as we said. Again, as we said, we don't know the small risk of the dose or small doses. We're not sure what are the changes, but we have to assume all of them or even small ones have some risk. We should not consider x-rays as routine. We always have to be prescribed. Get it right the first time so you don't have to expose the patient twice. And then they would cause damage. And we know we need to follow the ALARA concept. And we know what ALARA stands for, right? As low as reasonably achievable. Always have that in your mind. Okay, so how do we protect our patients? So there are some measures that we'll talk about in these 2 slides, technically. So professional judgment is the first thing. Definitely, that's what the dentists have to think about, making sure would actually the patient need x-rays or not. Follow the guidelines to see when and what type and how many x-rays you need to do. And definitely we have to do a clinical exam and review the medical history, the dental history before we expose x-rays or before we prescribe x-rays. And again, as I said before, a lot of times in offices, you come in for a visit before the dentist even sees you, the assistant will take x-rays, right? And this is kind of a routine that happened, but it's not correct. Technically, the dentist should see you, uh, do an oral exam, and then with the history that you have with that office, if you're again not developing any caries, if they can really check them and see there's no problem, then technically they should not prescribe x-rays. But again, we should follow the the guidelines. That's what we need to do. And there is a part in the book where it kind of really describes each patient type and when do we need to take x-rays or not, if you want to take a look at it. Anyway, the technical ability of the operator, again, this is talking about how we can protect our patient. So the better the operator, the better you are, the more that you practice here, definitely you'll have better understanding of how to take a better x-ray. And then most probably we will not retake x-rays, right? And that's why we're practicing here, to get you as good as you can get so that you can get your x-rays within the first time without exposing the patient to retakes or to extra radiation. Okay, then another type of protecting the patient is the technique. How do we take the x-ray? So the exposure technique, and the best choice for exposure technique is the what technique? Paralleling or right? Paralleling, right? Not the bisecting, because the parallel would most probably get you correct most of the time. It shows you the best results. So if you can take paralleling x-ray, take it. And then the exposure factors, and we know what are the exposure factors, right? That we can change within the machine. Right, the voltage, the milliamperage, and the time. So kilovoltage peak, milliamperage, and time. These are the technical, right? How we do that, the technique that we're using, and the factors. So again, all of these play a role, and we talked about these before, so we know the effects of each one on the radiation, and we have to take this in consideration when we're taking any type of X-ray. Right. We cannot really. Yeah, most of the it's not we cannot, but most of the new X-ray machines, you cannot control these. So exactly, and the main thing that we're changing is time. Yeah, exactly, and these factors would change. Based on, again, if you choose, for example, an adult compared to a child, some machines will change that automatically for you. So it just depends. But these are factors that affects as well. Again, the exposure that we give to our patients. So other things with the equipment, the X-ray should maintain definitely some requirements such as filtration, collimation, and PID, length and protection. So again, we did talk about these, but these are things that also can protect our patient. And then the optimal film processing. So uh, if we can get our film to be processed without having any errors, then definitely we don't have to do any retakes. Anyway, so now let's talk about filtration, collimation, and PID in the next slides. So again, we kind of talked about that. What is usually the metal that we use for filtration? Aluminum, right? Because we have these aluminum discs. And that filtration absorb long or short wavelengths? Long. Because these have less penetrating um, power for our radiation, and we don't technically use them, and that's why we put in the tube head we have these aluminum discs, and these would filter out these long wavelength x-rays that are not beneficial for us. So if we talk about that, again, we did talk about filtration a little bit in the previous lecture, but we can divide it into inherent filtration and added filtration. So the inherent, that is already done within the machine. So the glass of the X-ray tube, the insulating oil, and the metal housing, or that seals the port of the X-ray. These are all will do filtration on their own without us having to add any type of filtration. So again, if you see that glass outside of the X-ray tube, this will give us some filtration, right? The oil will give us filtration, and then the seal will give us some filtration, because again, these are all materials that the X-ray have to pass through to be able to get out of the tube head. So that's inherent filtration. And then we can do added filtration, and that is the placement of aluminum discs, right? And usually they place it between the PID and the seal of the tube, where we see it in the picture. So the total filtration would be the sum of inherent and added filtration. And the measurement for that total filtration will be in millimeters of aluminum. Again, because how many discs we're placing and how thick these discs are. We can see, filtration without filtration. All good. Moving on. This is just a picture of tube head, just again as a reference. So we see the aluminum discs and all kind of different things. The PID. So this is a slide from the previous lecture technically, but again, it's mentioned here. So why not? We know the collimator and the PID, the position indicating device, and the collimator would control the and size, which would reduce scattered radiation. We have two shapes of the collimator, round and rectangle, and we know that the rectangle one would have reduced exposure up to 70%. And we have a limit of how much restriction should be, which should be about 2.75 inches at the patient end on this side. Again, we did talk about these before, but since we're talking here about patient protection, about the machines, same thing. So this is the collimator, and this is the size. That's the limit, the upper limit of the size that it has to come out as, the X-ray. And we know, again, it can be circular or it can be rectangular. Same thing for the PID. We know it directs the X-ray. It can be rounded or rectangular. We know different sizes. The longer the PID, the less the divergence of the X-ray, which means protecting the patient more. Machines. So some machines have recessed PID, which technically the PID goes into the tube head. So instead of starting from here, the PID would start a little bit more earlier, closer. Let's see. So the PID, for example, starts here, and the tube head is pushed a little bit more back of the machine. So even though you see it short, on the outside, but it's actually more, long. So that's some of the machines. So you'll have them as recessed PID. Appears short, but it's actually longer. Anyway, moving on. So again, parts of protecting the patient would be the film and the holding devices. The faster the film, we know that we have less radiation exposure, and we know that digital sensors would further reduce the exposure of the patient. And we have the film holding devices. We know what they do, and they're better because they would help us so they can reduce the film retakes, and we don't have to hold the receptor, or the patient have to hold the receptor, and so on and so forth. So again, these are all factors playing in protecting the patient. And then we have the lead or lead equivalent apron. We know that a protect the reproductive and radiosensitive organs or tissues. The lead apron has to have at least 0.25 milliliters of lead into it. And when we store it, we have to store it flat or hang unbent. This is important when you guys put these off, way to the, I'm sure Dr. Spina already told you, when you place them, you have to hang them up correctly, and then you have to lay them flat. Maybe you didn't hear him, but anyway, Yes, that's important because then if you bend it, then it has cracks in it, and then that means it can cause less protection for the patient. So storing these lead aprons is important to keep in mind. When you put them, you have to lay them flat, and again, not bend them at all as much as possible, so they again will not have any cracks in them. We know that we have the thyroid collar, and we know it is there to protect the thyroid gland, and it's not used in more general. Yes, extraoral radiographs, and can be attached or separated. Nowadays, some offices would not even give you the lead apron. Yeah, I think some of you told me that. Yeah, right? It just, huh? They would what? Yeah, there are a lot of offices now that don't do it, right? Yeah, because again, because of these digital sensors, it's not, I don't think it's even legal. I think you have to do it. But because of the radiation, reduction, digital sensors, and the collimation, all of that, they kind of say, well, no, no, no. I'm not saying about the extra oral. I'm saying in general. Sorry, I'm not. Yeah, yeah. I'm not. No, no. Usually with the panoramic, they would give you, but with the regular X-rays, especially with the digital Nomad device, Nomad X-ray, a lot of offices they would not even give you. Well, not a lot, but I'd say some maybe, and definitely the operators would not wear it as well. Anyway, so but we know they're important. We have to give it to our patients. So now that was all talking about the patient, right? All of these things and above, talking about how to protect our patients and what are the things that we have for our patient. So for the radiographer, technically the same measures, right, for the patient would be benefiting the radiographer, and also thinking about the time, shielding, and distance. So as you can see, limit the time that you get exposed, right? Which is technically don't be in the room there if you're going to be, but if you're going to be limited, increase the distance. We know that we have to stay away from the X-ray as much as possible, and then use shielding. And definitely we are using all of these when we do our exposure. So the radiographer should spend minimal amount of time, and it should be protected by at a great distance from the source. So time, shielding, and distance. Technically, this is what it means. You don't want to spend a lot of time in the X-ray room while you're exposing a patient. You want to have your distance, and you want to have some kind of shielding. Continuing, so this is just kind of a summary of all the things that you need to think about. Follow all the patient's measures, avoid retakes, use radiation monitoring, use lead apron if needed, especially when you do your Nomad, right? When you have to be in the room. So why not use your lead apron? Protective barriers, shields do not hold the image receptor for the patient. Yes, definitely. Avoid contact with the tube during exposure and remain, yeah, 6 feet away at least. And at yep, it is because that's what in the picture, right? So again, because now we sit outside of the patient room anyway, so this is not really as relevant maybe to us, but that's the most safe um, degree or angle where you would stand if you're exposing someone. That's the least exposure that you would get if you're exposing the patient. Again, this is the patient head, that's the radiation, so you'll be 45 degrees to the radiation technically from the existing primary beam. Okay, a lot of already known information. So now, since we start having these handheld devices such as the Nomad, um, there are some rules for these. Technically, you should only use it when you don't have wall-mounted device and when you cannot move the patient. But again, nowadays we use it all the time. Most offices would use these because it's easier. You don't have to buy, you know, a lot of the different machines for each room. Instead, you can have one of these and just, move it throughout the rooms to take x-rays. I mean, it's much more convenient, definitely. And again, they're reducing the radiology, the x-ray that comes out of it. But at the end of the day, these are the recommendation. So you would not use it if you have a wall-mounted machine, because with a wall-mounted machine, again, you're outside of the room. It is fixed. You don't have to hold it and stand there. All kind of different things. So when they made these, they have to increase the filtration, inherent tube shielding, or filtration technically. So they put more filtration for the tube head, and then more shielding for the PID, and they have to put this lead thing, the back scattered ring shield, which is this. Huh? Yeah, an acrylic, leaded acrylic back scattered ring shield. Yep. That's a good name. So they found that it doesn't have greater risk than the regular mounted if you follow the protocols correctly. You want to hold it with both hands, kind of put it in mid-torso height, right? Remain within the back scattered shield protection zone. So if you look at the picture, technically that's the protection zone. So you want to remain in that zone when you're taking your x-ray. Position the PID as close to patient face as possible, and do not use it if your back scattered shield is not fixed to the unit. Huh? The Nomad? The what? No, what are you talking about? The, why they're not using it? Why they're not using it? For sterilization purposes, they're not using these? No, they're using it. Aren't you using that in the off and now with Dr. Sweeney? Don't you use the yellow one and all of these colored handheld? And then what do you use afterwards? The snap array. For the snap array. Yeah, the snap array doesn't have a ring, but these have. You use the bite tabs, right? Yeah. Huh? You use the bite tabs, the sticky things. Without this, I think that will be next semester. So he's getting you to know the things out of, without having that. And then I think next semester, I don't know, because again, some offices use them, some offices would not. So it's better to, I know we have it some way, we have it set up some way, but yeah, no, I mean, still offices use it. It's better to use it. But at the end of the day, you'll see when you get more practice, sometimes you prefer, you prefer the snapper. Some people prefer the snapper because it's just easier for them to work with. No, right? With the snap array? But how didn't you use the wired? You're using the wired one, and you don't have that ring that has all these three in it? Yeah, most probably then that's next semester, something like that. Most probably. Because I mean, next semester, what are going to do? I know we have the the phosphorus plates too. That's what we're doing next time. I don't know. I have to get with Dr. Espina tonight. I'm teaching 2 labs. Yeah, I got. Yeah, I got 12 of you. Huh? Yeah, I know. Have 12. So we'll see. I don't know. I follow Dr. Espina's pace. Whatever he does, I do that. He's the instructor. He's the radiology instructor. So he's the expert in that matter. So follow whatever he tells you in the lab. Moving on. Radiation monitoring. So these are the radiation badges that we used to give the students before you guys started, and then we didn't care much about you. No. So, they even hygiene, they used to use them, then they stopped, and we continue using them for a little bit longer, but then we found out that it's not required, and we never ever got any problems or issues with any of our students. So technically it's a small badge, as you can see it there. And maybe Dr. Espina showed you that, right? Nah, some other time. You can ask him, he can show you. So it's a small badge that you wear on the side, of your, usually on the front, on the front of your clothes or by the waist level. And you put it as long as you're taking x-rays. And technically it has a film in it, to make it simple. It has a film in it, and that film will get exposed as much as you get exposed to x-ray. And then we send that film to a company, and the company would read out how much exposure that film has. And then if they found out that you're getting exposed too much, then there is a problem. They'll let us know, well, you're having a problem because most of your students are getting much more than normal radiation levels. Okay, so again, as most I don't think any offices use that now. Some of them use a different type of a measuring devices we'll talk about, monitoring devices. Technically, for outside of the rooms or something like that, they might be able to use it. But these are the badges again that usually people that work more in the industry, like with the CT scans, they like the radiology technicians would wear, because they have to keep track of how much exposure they're getting. And again, for us in dentistry, we're not getting that much radiation. So a lot of agencies do not require it in dentistry. And as I was looking, some, I think it depends on the state as well. So some states would require it if you get exposed to certain amount of radiation, and some states would not. Anyway, so again, these radiation monitoring can be an area, as we said. So you can see, for example, we put one outside of the x-ray rooms, and then we can see if there's any x-ray passing through the walls to make sure that, the machine is not leaking x-ray too much, or our walls protection is not, if it's good or not. So it's good to have these. And then we have the personal monitoring, which we call dosimeter.
That's what I was going to say.
Yes. So these are the dosimeters, and then again, there are different types of them. They're attached to the outside front of the radiographer. You wear it, and then you send it to the company, and then the company would report it to tell you how much exposure you got. Badges, right? So one example other than these regular badges is the direct ion storage dosimeter, or DIS. And this is just like a USB. As you can see, you wear that, or you put it on a machine on outside, and then you just hook it to the computer and you log into the website, and it will show you the readings. You don't have to send it to a company to read it for you or anything. So it's just more convenient, and that's how it is done. And last but not least, the maximum permissible dose. So this is to tell us how much exposure, X-ray exposure, we can get. So this is the equivalent to exposure that do not cause any detectable damage, right? So this is how much we can get exposed. without having any damage. And then there are two measures, one for radiation workers, which include us, and then one for general public. So for us, does not exceed, yep. Are you still something? Is that, are you still there? Yes, I am. Is this still recording? Yes. Okay. So yeah, 50 per year does not apply to pregnant members or people under 18. And then the DPM, which means the maximum, I'm sorry, MPD, maximum permissible dose, for dental workers, similar to any other radiation worker. So we're not different from people that work, radiology technicians or anything like that. We still have the same measure. I mean, that's the dose that is measured for us. So compared to people that do not work in the radiation field or in dentistry, do you think how much they're the permissible dose? 5. So you can see where it's 1/10 of the exposure that we get compared, is considered safe for public compared to people that work in radiation. So we're getting, again, because we're working with these machines, so our maximum permissible dose is higher compared compared to people. Any questions? What?
Like all of them, except the tube head pictures, right?
Yeah, tube head. Yeah, I don't.
You won't put that one on there.
There's no pictures. Like I'm not going to ask you about pictures or anything. No, honestly, like most of the information, it feels like, huh? Yeah, like it's, I don't know what you call that. Like it's just talking. We're just talking here about things, But again, there's a lot of tons of things that can come out of here. So, yeah, there's a lot. So,
If I had to guess, probably the whole direct indirect. To make sure you distinguish between these topics. So those topics, go back and highlight those.
well, usually, there's always a question, at least one question out of each slide, at least, either question or what do you call that? True and false. So there's always something out of these. I was I was heading for a hair, but then I made a head. He's flying and kicking someone. No, yeah, that's not going to be. Sitting down, I don't know, jumping around. Let's stop